If you look here, we have so many newer things that have happened. You look at the multimodal imaging. So this is a picture of an OCT angiography where you can see from the OCT angiography, you can see here a neovascularization. And the beauty is that if you go to the you can actually demonstrate a flow on a B scan, and you know that this is an elevated NVE. You look at the peripapillary area where we have NVD, and there is, you can identify the blood vessels and do a B scan and demonstrate a flow within this within these vessels without your view being obstructed from the normal leakage. We have also learned to look at the retina, which Dr. Manpreet would be talking, in different slabs from the surface to the deep. And we have identified that fluorescent angiography would not be able to tell us picture about the ischemia which is occurring in diabetic macular edema, which actually happens at the deep capillary plexus. You can see here the ischemic zone of capillary non-perfusion. We also have learnt algorithmic approach to managing diabetic retinopathy, and this I will allude at a later point. And we have newer lasers available like the Navilas and the micropulse, and we all know that how beautifully anti-VEGF take care of diabetic macular edema, and Vishal will be covering about the vitrectomy in diabetic macular edema and diabetic PDR cases. So this is a course, practical and protocol-based management of DME, and I have a galaxy of well-known speakers, and we have the keynote address by Dr. Bhaskar Gupta, who is from Southampton. So here I have Dr. Manpreet. Dr. Neeraj Sandhu has not been able to make it due to an emergency. We have Professor Atul Kumar, who will be joining in a short while. Dr. Dinesh is coming. Dr. Vishal Agarwal from SMS. Dr. Ritu, Dr. Bhaskar Gupta, and that's me. Dr. Bhaskar is a consultant, we are a surgeon, and all the galaxy of speakers don't need any introduction. But Bhaskar Gupta is new to for many of you, so I'm introducing him. He is a consultant surgeon from the University Hospital Southampton. He did his post-graduation in India, followed by DM research project under Professor Shobha Shivaprasad at Moorfields, and he has over 50 peer-reviewed publications. So after our session is over, we'll go to an interactive session of about 12 minutes, where we'll be putting up some clinical situations and discussing it openly between all of us, and you are free to answer questions, ask questions. So the definition of diabetic macular edema over the years has changed. We used to define the clinically significant diabetic macular edema. It's become much simpler now. We have a center involving diabetic macular edema, which is in the central subfield, and you have a non-center involving diabetic macular edema. If you have a center involving DME, you treat it with anti-VEGF. If you have a non-center involving DME, you identify the leaking microaneurysm on an angiography and treat it with focal laser by the ETDRS protocol. We have learned more about pathomechanisms. So we know that there's a thickening of the basal membrane, there is apoptosis of pericytes, dropout of pericytes, there are changes in the endothelial cells, and there are changes which are happening which cause stickiness of the endothelial cells, and which leads to exudation and retinal hemorrhages and formation of microaneurysms. And because of the ischemic factor, predominantly VEGF, we have ischemia, and we have capillary non-perfusion area, which eventually leads to formation of neovascularization. We have numerous biochemical markers. I will not go into the details, but the triggering factor is hyperglycemia. This hyperglycemia leads to a cascade of events which occur. There is a PKC activation, there is an advanced glycation end product. So this basically leads to vascular endothelial dysfunction, and that you can have retinal ischemia, so you treat it with laser. Then you give steroids which act to reduce the permeability of the vessels, and we have against VEGF, so we have anti-VEGFs which take care of the increased VEGF, and then we have other factors for which newer drugs have come, but not yet being clinically so much used. They are still experimental. So there is a disruption of the blood-retinal barrier. There are certain hematological and rheological changes, and we know clearly now you can see here the capillary non-perfusion, how beautifully a microaneurysm forms. And we have a multitude of these problems which have to be taken care of in a systematic manner. I'll be alluding later on the importance of the artificial intelligence, and we can now screen for diabetic retinopathy without the patient being next to you. You will get the images and you can accordingly advise the patient. And mind you, this will not lose, we are not going to lose our jobs by artificial intelligence, which I'll show you later on. I alluded before this that if you have a central involving diabetic macular edema, we don't go ahead and this is the laser which I had done way back in 2004. You can see how close to the fovea we used to go when we didn't have anti-VEGFs available. These patients used to do well. However, if we have anti-VEGFs with a central involving diabetic macular edema, today we'll be injecting anti-VEGFs, and for the non-central involving, we'll go ahead with lasers. So if you have a central involving diabetic macular edema, if the patient is symptomatic, you treat with anti-VEGF. If the patient is not symptomatic, that means the vision has not come down, and we will discuss this part of the clinical trials. Then we can wait and watch, and always metabolic control should go in all stages of diabetic retinopathy. Metabolic control is very important, whether it is non-proliferative or a proliferative diabetic retinopathy. If you have extra foveal macular edema, you identify the macular aneurysm by the angiography and you treat it with focal laser. If you have a PDR patient, then with a PDR, if you have DME, which you treat with anti-VEGFs and then do laser, and eventually if you have vitreous hemorrhage, which Vishal will be talking about, you do vitrectomy. If you don't have any diabetic macular edema, central involving, you can go ahead directly with PRP. In DME or diabetic retinopathy in a pregnant woman, it's important not to inject anti-VEGFs. So if you have a diabetic macular edema, you could either wait or you could inject steroids. But if you have laserable PDR, go ahead and do the laser. Laser is not a contraindication. So just a little bit about the metabolic control. This patient refused any intervention. This slide actually I have obtained from Dr. Mangar Dogra. We have a patient, so this patient was followed very intensively for 6 months, and this is after the very good metabolic control, the right eye and the left eye, the patient did extremely well. There is one other patient who walked into my OPD who had never been to a diabetic. 8 months after dialysis and metabolic control, see how the picture is beautifully changed. So it's very important that Dinesh will be covering this. It's very important that we have a good metabolic control. And just to tell you a little bit that micropulse laser may have, Dinesh, why don't you come and join us here? Micropulse laser is effective without scarring. We can treat diabetic macular edema, which shows that microperimetry is benefited. So the take-home message is good metabolic control, use of anti-VEGFs, focal laser for non-central involving DME, ranibizumab for PDR, and with a diabetic macular edema, and one could defer laser, and of course vitrectomy, which I will be mentioning. And I will just stimulate your thinking process. You have a patient with persistent diabetic macular edema, the cystoid spaces. Patient has received 8 injections of anti-VEGFs, 4 injections of Ozurdex. Ozurdex is not available in the market. What are we going to do? So these are the sort of panel discussion we'll have, and we have some solutions for this. So thank you very much. That is my introduction for my speakers. I would now our first speaker, Dr. Manpreet, is just reaching. I will request Dr. Bhaskar Gupta, who is from, to give his keynote address. And actually, his keynote address, which was mentioned in the AIOS, I had actually requested him to change it to some extent so that we can learn from him how they do it in the UK. Dr. Bhaskar.